Hello, everyone. We will be starting our next session now.
My name is Andrea Hieronymus, and I am the Mental Health Services Program Manager with the Division of Behavioral Health, which is under the Department of Social Services. Today's presentation will include an overview of the publicly funded behavioral health system with a focus on services available for youth and include a panel of community mental health center providers serving rural areas. They'll be here today sharing the creative ways that they serve their youth clients and families, including the use of telehealth. In addition to learning about the available services, participants will learn how to make a referral and how these services can have a positive impact on their lives or on the lives of those that they refer. So I'm really pleased to have with me today panelists from 3 of our community mental health centers that are offering services to individuals who are living in the rural areas of our state. It's one thing for me to describe the services that we have, but I think it's important for you to hear from those who are engaged in actually providing those services. I'm very happy to introduce today Lindsay McCarthy. Lindsay is the Executive Director of Southern Plains Behavioral Health Services, which serves the counties of Todd, Tripp, Millette, and Gregory. Also with us today is Jason Lilick. Jason is the Executive Director of Three Rivers Mental Health and Chemical Dependency Center, and that agency serves Perkins, Corson, Dewey, Ziebach, Walworth, and Campbell counties. And then finally, also with us today is Chris Taggart. Chris Taggart is the Youth and Family Services Supervisor for Lewis and Clark Behavioral Health Services, which serves a 7-county area of southeastern South Dakota, including Bon Homme, Charles Mix, Clay, Douglas, Hutchinson, Union, and Yankton counties. So thanks to all of you for being here today. Before we get to the panelist questions, I want to just provide a short overview for you today of the Division of Behavioral Health. Our division supports the mission and vision of the Department of Social Services by strengthening and supporting families through the oversight of the publicly funded behavioral health system. In other words, our role at the division is to provide the funding, the resources, the support, and the technical assistance for our providers, really behind the scenes. We're not the direct provider of those services. So we're the supportive cast, I like to say. And when we reference the publicly funded behavioral health system, what we're talking about are funding through various sources, including the federal and mental health block grant, the substance abuse and prevention block grant. We have other federal block grants that we work with. State general funds and Medicaid, all of those different sources fund the mental health and substance use disorder treatment services in the state of South Dakota. Included in this funding, we provide funding for 11 community mental health centers, 33 substance use disorder treatment providers, 20 prevention agencies, as well as 3 prevention resource centers. So here you see a color-coded map of the state of South Dakota. This is our Community Mental Health Center, or CMHC map. To ensure that the mental health services are available to all residents of our state, we have assigned a grouping of counties, which we call the catchment area. And each of those community mental health centers serves that grouping of counties, so you can kind of look at the color coding to see the different areas that these 3 fine folks are from. Our community mental health centers provide those short-term mental health treatment services that you might be familiar with. So if somebody is going through, maybe a crisis in their life, they're dealing with some anxiety, perhaps it's been loss of a job, a divorce, death of a family member, things like that, and they need to go in for a short-term period of time and be able to kind of talk that over with someone, they are able to receive those very short-term therapy services at a community mental health center. But additionally, they are able to get services even beyond that, some more specialized services. The priority populations for our community mental health centers include adults with serious mental illness and children under 18 with a serious emotional disturbance. I will tell you today we're going to really be focusing on those services for children and families, but if anybody has some specific questions about the adult services that are available, you can feel free to ask us at the end of the presentation. We also have a Division of Behavioral Health booth here at the conference, so you're always welcome to come over and ask anyone at the booth. We have a variety of materials for you to pick up, so those are available as well. The Division of Behavioral Health also contracts with substance use disorder treatment agencies. You can see this is another color-coded map. It's a little bit different than our CMHC map. So where our community mental health centers have kind of certain areas of the state that they focus in on and provide those services, the substance use disorder treatment services are more based on the type of treatment that is needed. So you can see from the slide that they do provide a wide array of services, ranging from outpatient treatment services, the low-intensity residential treatment services, the more intensive inpatient treatment services, as well as detoxification services, and then the other specialized services that are listed on that slide. Again, anyone wanting additional information can stop by our booth and we'd be happy to answer any questions related to that. The other part of the Division of Behavioral Health would be our Office of Prevention and Crisis Service. This is kind of 3 tiers, I guess, of those services, if you will. It starts with substance use prevention. Our department, as I said, contracts with 20 substance use prevention providers and our prevention resource centers. And all of those receive funding that are able to tailor their prevention efforts around the community that they're serving. So they're providing those prevention services within the community, within the schools, and then sometimes individual prevention services. And they're always based on evidence-based programs that they provide. We have our other tier would be the suicide prevention. Governor Noem made suicide prevention a priority in South Dakota. And in doing so, our division has a program manager and team who are dedicated to suicide prevention campaigns. They oversee our South Dakota suicide prevention website, and that website location is listed on the slide. And they also meet regularly with stakeholders in the community and work on various suicide prevention initiatives. And then finally, our Office of Prevention and Crisis Services has our 3 pillars of crisis care. So the first pillar is someone to talk to, so 988. A lot of you may be familiar with 988 that went live in South Dakota in July of 2022. And so that is just the number that you can call anywhere in the state or really anywhere in the United States. So if someone is in a crisis, they can call 988. If they're having any suicidal thoughts, they can call 988. And there's going to be someone on the other end of that line who can assess the situation and get them the help that they need. The other pillar is the idea of someone to respond. So we have mobile crisis teams and we have ABLE eCare in our more rural communities. So for example, in the Sioux Falls area, so Minnehaha and Lincoln County, one of our community mental health centers that would be Southeastern Behavioral Health Care, and they have a mobile crisis team. So if a police officer or if a sheriff responds to a call and they find out that there is a mental health crisis of some sort, then they are able to activate that mobile crisis team and they will come directly to the scene and meet with the individual or individuals. They can work on de-escalation. If they need further intervention, they can get them the help that they need. And so that's very important. The other part of having that mobile crisis care, and they can do that also in the rural communities. So the ABLE eCare is more of a, like on a laptop. So they will provide that care. So it might be more like that telehealth idea, but the same idea, being able to assess and being able to provide the interventions that's needed to get that person the help that they need. And then finally, the third pillar is somewhere to go. And so you may all be familiar with, some of our bigger areas in the state. And then in Yankton, we have our Human Service Center, which is our only state hospital. And so those places aren't necessarily within the communities, especially where some of our rural residents are living. And so our division has been very active in creating some regional facilities and to help keep people closer to the communities where they live. So if it's not right within the community, it's certainly not several hours across the state, so that they can go and get that treatment. And so these are going to be providing short-term residential crisis stabilization. So here, finding services in your area, we have our handy dandy QR code on here. And so if you use your smartphone to access that QR code, it's going to show you right to our website. And you'll see a map of the state of South Dakota, and you simply just need to click on the county where you live, or if you have a client, the county where they reside, and it will show you which community mental health center serves that county. Or you can also find out information as far as SUD services, about walk-in assessments, where you can go in person. They also have telehealth availability for some of those assessments. So all of that information is available on our website. You can also give us a call at the Division of Behavioral Health. We'll have that number at the end, and we can certainly walk you through how to get to the provider that you need. And so, Lindsay, with that being said, can you please explain what happens next when someone is either going to make a referral to a community mental health center, or perhaps call and schedule an appointment themselves?
Certainly. Sure. So our referral process, is that working? There we go. Our referral process would look a little bit different from one agency to the next. But the concepts or the steps are going to be pretty similar. So the first thing would be just picking up the phone to make the call. And the resource to being able to just click on the county, and there's the information for the CMHC that is in the area, or the substance use treatment facility. Right there, you can call and talk to them about what their process is, but typically it's going to be gathering background information, demographic information, contact information, and a bit of information about the nature of the problem. What are you referring them for? We do seem to have a wide variety of people who refer. Sometimes it's the healthcare facilities, sometimes it might be the jail, it can be a loved one, it can be the person themselves wanting services. And so once we make her receive that phone call, at Southern Plains anyway, we would send it out to staff or have it assigned to a staff member to get in touch with that person, to then get that opening session scheduled so they can come in and complete opening paperwork. I know some of the other centers, they do have even just walk-in times to do assessments, and so it does depend on the center, but ultimately you're coming in to complete paperwork. And I feel like our process does look a little different compared to just going into a regular medical clinic. If you're physically sick and you need to be seen by a doctor, you go in and you can sit and wait as long as you need to until they can get you in. We can do something similar, but there is a process that we have to do of going through and getting your consent to receive services. We have to get the authorization so we can talk to others about your treatment. We also do means testing to see about who can pay for your services. If you've got insurance, great. Otherwise, we do receive funds through the state to offer services for free to those who qualify, depending on the number of people in their household, as well as their income. So we'd go through that with them. If they don't qualify, we do still also have a hardship process, and it's another form to sign, to complete, but that can get the services for them for free. We'd go through a treatment plan, an initial assessment to identify, what are their strengths? What are the things they've been struggling with? How have they gotten through these things in the past? What are they doing differently or dealing with now? And what can we do to help? What services can we offer to help assess and assist them in this time? We have requirements to update this paperwork every 6 months. So I think that looks a little bit different. And if that paperwork isn't updated, we're not able to see, and so continue to see the client if they're not coming in, meeting with us regularly, getting that paperwork updated. And that's one thing that I found with schools. So we see anybody from birth until death, so if you're questioning, oh, who do I reach out to? Call, make the referral. There's probably some kind of service that we can offer to help with this individual. And so, yeah, it's important to, for everybody to know too, that like the client does have to make the effort, but the nice thing is we're community-based. So we ultimately can see the client wherever they choose, whatever is most convenient to them. If it's in their home, great. If they want to meet in the park, fine. If we can see the child in the school, wonderful. So it really can, what is most convenient to them. But if they're not interested, at times that can be challenging when the school is like, why aren't you getting this child in? Well, they didn't come in to sign the paperwork, or they have declined services but didn't sign a release, and so I can't share that with you. So there's definitely some challenges there, but ultimately it's a pretty easy process to just get in, make the call, and then we'd set up that appointment directly with the person.
Okay, so on this slide, we're looking at our children, youth, and family services. So as I said before, one of the priority populations for our community mental health centers are children with serious emotional disturbance and their families. So these are comprehensive services, including case management, individual therapy, psychiatric services, and then 24-hour crisis assistance as needed. And there's even more detailed services beyond that. So Lindsay, since we're already talking, could you explain some of the services that are provided under what we call this CYF, Child, Youth, and Family umbrella?
Certainly, and you described it just as I was thinking of it. CYF, Child, Youth, and Family, is the umbrella over top of all of these services that we're able to offer to families and their children. The child, a guardian would come in with the child, complete the opening paperwork, we'd do the initial assessment, do the treatment planning to see what services would be best for them. As Andrea had pointed out, we've got about 4 different branches or kind of pillars of services that we're able to offer. The first one being the case management services. So we're able to link the family to local resources, connect them to things that they need, potentially help them fill out applications, connect them with the local Medicaid office, help the parent work on applying for jobs, filling out those applications, getting to medical appointments. We work as an advocate for them with the school system. They might be struggling with IEPs and getting the school to listen. So we can be there on their behalf to help them and work with other professionals through those case management services. We also provide the counseling services that can be individual as well as family or group counseling. We at Southern Plains, I think everybody knows that recruiting staff, it can be challenging, especially right now. And so we've had to get a bit creative in how we can continue to offer these services. And all of us sitting up here, we serve a large area. And so telehealth has really been advantageous for us to be able to reach adults and children through the use of telehealth. Somebody might go to one small community that's an hour away, 1 day a week. Well, we all know that crisis and services don't just happen 1 day of the week when we're there. And so through the use of telehealth, we're able to connect with these children, their families, the school systems, to continue to provide those services regardless of what day of the week it is and what our schedule looks like and when we're in those locations. So we've been able to use telehealth to do that. Southern Plains did partner with Lewis and Clark to receive the USDA telehealth grant. And so we were able to put telehealth equipment in basically all of the schools in Todd and Millette County. And so that's been extremely helpful because there might be an elementary school 30 miles out from Mission, the main school. And so we're able to connect with the kids there. Again, the families, provide psychiatric services, things like that. Through the use of that telehealth, we've also partnered with Southeastern Behavioral Health Care to offer counseling services through telehealth. This was an attempt to help keep down our waiting list. We know when people reach out, they want services yesterday or needed them yesterday versus waiting weeks to get in. So that was an attempt to help decrease the waiting list. And really, from the referral process, we start asking right away, would the person be interested in telehealth? Are they able to do that? Do they have the capability, something that they could connect with? A private area spot that they would be able to meet with us and discuss very personal things. So we definitely use the telehealth where it can be needed. It's beneficial though, just to be able to make that continuity of care, continue those services regardless of what day they need to have those services. We've also been able to bolster our groups. There might be a child in White River who really could benefit from MRT, moral recognition therapy, but we don't have enough kids there to do a group. But in Gregory County, there's 4 kids that are ready to do a group. And so we're able to connect them through telehealth to these other students. And so that's been really beneficial for us to be able to get the kids the model of the therapy through the telehealth platforms. We also offer DBT, or dialectical behavioral therapy. We have an in-person group, but you also can connect by telehealth if something has come up, or we do have people that drive one way an hour just to attend group. Something comes up, they've got an event for their child, and so they're gonna do telehealth that day rather than driving. So we've been able to utilize that. We also can do group through or for aggression replacement training, another therapy, as well as functional family therapy. We have contracted with Southeastern Behavioral Health to offer that therapy. And since now we do a direct referral to them to offer that family therapy in the home through telehealth. We have, and we'll talk more about our systems of care program, but we've been able to utilize other services within our agency to help connect and get the telehealth going in our areas. We also have the psychiatric services. And so this would be working with the school, the family, to assess the child's needs, look at behaviors, and if medication is an option that would help benefit them. We work collaboratively with the schools, school staff, med-trained staff, or the school's nurses to administer that medication and really help provide education to the families on that medication, appropriate dosing, where to store it, and just the safety planning in general with them. Kind of the last or 4th area of services that we're able to provide is the 24-hour crisis services. And all community mental health agencies are required to offer this 24-hour on-call emergency service. And so this is for adults and children. Any of our services or clients would be able to call and utilize that. They could be somebody in crisis, or it could be a call from the hospital, school, jail, just somebody on the street seeing somebody struggling. And then we're able to either go to the location, to the hospital to help assess and work through a safety plan for the individual, or we can use telehealth to help connect to those things and do that assessment.
Thanks, Lindsay. So Jason, to bring you into this conversation, could you talk a little bit about the trauma-informed approaches that are provided, including how you have worked with individuals on the reservations?
Absolutely, thank you. So when we start with trauma-informed, I think everybody is well aware that trauma is a big thing. It's occurring. I believe that trauma comes down, or mental health comes down to 3 things: what happened to you, what you've learned, and what you haven't been taught yet. And that's kind of where our role in helping people learn differently and also be taught new things. The other aspect of trauma-informed approaches is coming down to 3 questions. And these 3 questions I start every session with, and the questions are: how are you feeling? What is your goal? And who can you ask for help? In fact, I carry one of these with me everywhere I go. It's a feelings wheel. If you haven't seen it, I know everybody has, but why that's so important is because when we work with individuals with trauma, they often have a difficulty in recognizing feelings, emotions. We even have a difficult time. If I ask most of you, how are you feeling today? I'd probably get good, fine, okay, but those aren't feelings, aren't emotions. Helping people, especially those that have experienced trauma, to have the language to define their emotions gives them the ability to control and manage their emotions. The second question is, what is your goal? This is helping individuals move from an emotional part of the brain to a goal-oriented part of the brain, and setting a goal for today. It can be any goal. It could be for the session. It could be for later today, for tomorrow. It's just getting people thinking future-oriented and goal-oriented. And the last question is, who can you ask for help? And it doesn't have to, it can be related to the goal, but it doesn't have to be related to the goal. And why this is important is that we all know how difficult it is for individuals who experience trauma, people who are experiencing mental health crisis, to actually get out and ask for help. So every session, we incorporate these three questions. How are you feeling? What is your goal? And who can you ask for help? This is what we do in every session. And this is really helps back upon the tenets or the guiding principles of trauma-informed approaches, which are establishing safety, trustworthiness, transparency, peer supports, collaboration, empowerment, and cultural and historical issues. So why this is so important when we read through the guiding principles or know these guiding principles when it comes to safety, trust, and empowerment, collaboration, these are all things that we do. That's what we do as therapists, as providers, as case managers. The other aspect when it comes to working with individuals on the reservations, and we serve two, the Standing Rock and the Cheyenne River Nation, is the identification and recognition of cultural issues. This has to do with their beliefs, past trauma, systemic trauma, organizational trauma, acknowledging that and incorporating that as part of the narrative, as part of empowering them to have their own story. And so when we have individuals that we're working with, indigenous populations, it's really this cultural identity and sense of self, rather than just being, I am broken, I am a victim, I am. It is them being empowered. And one way is that some of our therapists, and we have 2 enrolled members that are on our team, and then we have 2 others that live on the reservations and have worked hand in hand with local organizations, is really utilizing some of this cultural identity. One is living and doing in a good way. And that's essentially, how do you help our clients lead that while being fair to themselves, being fair to others, while at the same time doing good by their community and by their family. Another one is living in harmony and living in balance with others, which is still incorporating how do they live in balance with their community, with the environment, with their peers. And then there's the 7 directions. I don't know if you're familiar with the story. I'm not going to go into it, and I'm not an expert, but it's a really, I think it's a really great thing for creating mindfulness, is that in some of the Lakota culture that the creator gave 7 directions and the creator hid one, and that one direction is hidden within you. And so it's really utilizing that direction inside you and working with the individuals. What is that direction? And putting that on the shoulders of living and doing good in a good way. So I think that's really important as part of the narrative to helping our youth and children tying back to their culture to be empowered, because it really seems like no matter what, people are always looking for their roots. They're looking for things that can ground them and to be a part of that, because everybody wants to be incorporated. Some other things that we do on occasion is wiping of the tears ceremony. We involve local communities as part of that collaborative effort. Also, honoring the past and honoring ancestors. Many of our youth participate in the Bigfoot ride, which happens in the winter, where they travel from Standing Rock all the way to Wounded Knee in December, and also the Chief Ride. The other thing is getting them involved, which is part of empowerment, is some of our youth participate in the missing and murdered Indigenous women, and they participate in the walks and the awareness. So that's one way that we try to incorporate that back with our youth on the reservation. Some of the things that we do just in general is, we start at assessment and we assess for trauma. We use the pearls for our youth. Other approaches or modalities that we use are trauma-informed CBT, which recognizes false beliefs and unhealthy behavioral patterns, and new ways to cope, which include expressing emotions, which I talked about the first. We utilize EMDR. We have 5 out of our 7 therapists are EMDR trained. We utilize that a lot, especially for, dealing with trauma, but it's in my opinion, it's a good addition to talk therapy. Also narrative therapy, which I've kind of alluded to through some of my previous comments, but given meaning to experiences and challenge their beliefs of being broken or being powerless, and not having that emotional hold with their story from the past. And when it comes to substance use disorder treatment, we also utilize Seeking Safety, which is a trauma-informed curriculum, and Medicine Wheel, or the White Bison, which is specific to youth. So those are some of the trauma-informed approaches that we use, particularly with individuals living on the reservation.
Okay, so the SOC, or Systems of Care model, has been receiving increasing attention over the past couple of years, particularly when we're talking about the services that are delivered to the schools by our community mental health centers. So Jason, I'm wondering if you could explain the SOC model and how this approach is different from some of the other services that we heard Lindsay talk about and that you had even just talked about previously.
Yes, so this is going to share some of the same things with our other approaches, but Systems of Care is a strength-based, family-driven, and culturally competent approach. I see it as solution-focused, brief solution-focused. We're really trying to get people's needs met. And when we go through the Systems of Care process, it's much different in enrolling somebody than scheduling. We have to schedule an appointment, but it goes by a lot quicker. It's not as much paperwork because the individual is usually presenting with a need and not necessarily a crisis or some type of major mental health issue. So we are helping families and children not get deeper into our system and to get the needs met early on, because some of these needs in the 8 holistic, or the 8 domains that we have, a lack of these can result in reduced health or mental health. So that's one of the big differences. It has a preventative nature. Just like other approaches, it's holistic, but when we go through the Systems of Care, we do a needs assessment across all of those 8 domains to identify the needs. it's very much collaborative. We collaborate with the school, we collaborate with law enforcement, we collaborate with DSS, community health nurses. We get a lot of referrals, or we refer other, it's bi-directional. They refer to us and we refer them back for some of the same services. So one of the big benefits of systems of care is it's not treatment, it's getting needs met. And with that, instead of going somewhere to receive a diagnosis, you don't have to have a diagnosis to receive this treatment, which a lot of individuals avoid services because they don't want to be labeled. They don't want the diagnosis, and they're uncertain of what treatment is. So if we are able to work with individuals and meet their needs, then we have a reduction of emotions. Because when we have negative emotions, are those, angry, sad, scared, all those things represent an unmet need. When needs are met, we're usually happy, excited, optimistic. So meeting needs helps with even emotional regulation. So one of the other things with systems of care is it's meeting specific needs and having action plans that identify what is the need and who can help. So there's some responsibility, a shared responsibility. It's also an inclusiveness of all getting those peer supports, which I spoke to earlier around trauma-informed, is getting those supports around them. So I found that systems of care has been really key in preventing individuals from falling through the cracks, because we are getting individuals, especially from our native areas, and they are now coming to receive services because they're receiving help. It's non-stigmatizing. There isn't a ton of paperwork that has to be done, because that's part of the trauma that they've experienced. And so reducing that, and then we're able to identify, this person has a higher level of need. In fact, they're suffering from some type of severe mental illness, or they're suffering or subject to some current mental health crisis. So it's much easier once you've had somebody in the door, you've built relationship, which is that trust piece and transparency. You're much more likely to get effort out of all parties. So, and all of these have a component of skill development, and I'll talk about that a little bit later, I think.
Thanks, Jason. Chris, I want to bring you into this conversation now, because our audience probably doesn't realize that Lewis and Clark was actually the pilot site when we brought in the systems of care model to South Dakota. And Lewis and Clark has continued to champion this program. I think that you have our largest, or at least one of our largest systems of care program in our state. I'm wondering if you could share some of the success stories that you've seen through SOC.
Sure. So in 2014, Lewis and Clark piloted the Systems of Care project. It was a outcome of a meeting of the minds around the table at our local frying pan. From that, it has expanded. We currently have 8, soon to be 9 systems of care providers at Lewis and Clark, and there are now, the Systems of Care program is in 10 of 11 community mental health centers across the state of South Dakota. So it has taken off and has been a great benefit and a great asset, and an additional service that we can now provide. As far as success stories go, I could talk all day long about some, but just some specific ones. We had a mother of 3 children, single mom, was not employed, living in the basement of her parents' home with the supportive systems of care staff, they were able to help her find employment, help her find housing, get those supports in place. And she's now living in her own home independently, raising her children, has a job, and is leading that independent life. We, in our rural areas, we have found that, as you well know, resources are not as great as they are in some of our more urban areas. We do have rural SOC providers, and they have had to get very creative with finding resources for their families. We have found, even in Yankton, we have found that in order to build those relationships with our other service providers, accessing those resources, it's very important to get out there, spread the word of what we do, pound the pavement, talk to people, talk to community members, to other meetings, just to let people know that we're out there and what we provide. I have a coworker who lives in a very rural area, and she just happened to be telling her friend what it was that she does and what that means and looks like. That friend then took that information to her Bible study group. And from then, that grew to people within the Bible study group wanting to help provide food or clothing or other resources, and then again, sharing that information with their friends. So she's really been able to grow those resources in her area just by word of mouth. Some other success stories are things that we're working on through our Systems of Care program. We've provided some gloves to all the kids in some of our rural schools. We've provided some pool passes to some families in our rural areas. And then this year, my coworker and one of the school counselors in her area is piloting what they're calling an apple tree. And it is based on the angel tree that we're all familiar with that comes out at Christmas. This will be an apple tree for fall, for back to school. So they are looking for donations of school supplies, clothes, shoes, backpacks, lunch boxes, those types of things, to give to those kids whose families may be not able to provide that for them due to finances being tight. So they will be putting the word out and asking for donations. They're going to put boxes in churches and the grocery store, see what kind of response they get. And then they hope, if that is successful, to move that on to additional rural schools next fall. So we are pretty excited about that. I just wanted to reiterate what Jason kind of said, is there is no right or wrong way to enter services in a community mental health center. We have families that start SOC, then we identify them needing CYF or alcohol drug services or vice versa. So if they come in and in working with them, we identify other needs that they may have, we will help them navigate through our systems and get them connected to those other services that we provide.
Thank you, Chris. It's important to understand that a CMHC, a Community Mental Health Center, is an agency that is a connection to the system, or in other words, a connection to all of the services that are provided within that system. We talked about how this happens through the systems of care models in the school, but Chris, we haven't yet talked about prevention. I'm wondering if you could just talk briefly about some of the prevention services that are also delivered to schools.
Sure. In Yankton, we have a licensed alcohol counselor, addictions counselor in our school district. She is housed out of the district. She provides curriculum-based services to all 6th and 9th graders. It's called Project Success. They go through that curriculum, and it talks about drug and alcohol education, prevention, healthy coping skills, all things like that. So they are hit in both middle school and again in high school. She also does the drug and alcohol assessments or screenings for those youth who receive a drug or alcohol violation in the school, or those that receive a training rule violation from the High School Activities Association. So she screens them, she sees them at the school, and then makes treatment recommendations from there. We at Lewis and Clark also partner with the Boys and Girls Club, we were awarded a grant through the JDAI program, which is juvenile diversion, trying to work to lower the number of youth in the juvenile justice system. So when a juvenile receives a violation or breaks the law, our state's attorney reviews their case and decides if they go traditional court in front of the judge or if they go through diversion court. If the diversion route is chosen, what that means is that youth is on diversion for 120 days. They have to meet with a coordinator once a week. There's other things that they need to do. And if they successfully complete all those, then that charge is dropped off of their, it's off their record. So at Lewis and Clark, we partner with our diversion coordinator, and when the kids come into diversion court, we do a quick mental health assessment just to see if there are any needs, any mental health needs or any other additional needs that maybe we can get them going, either with counseling or systems of care or drug and alcohol, whatever the issue may be. We're trying to capture that early on, get some things in, get some prevention in, and try to steer them out of the juvenile justice system and off the path that they're on legally. And then if they have a drug and alcohol violation, they are also connected to a drug and alcohol counselor, and they do that screening as well. We oftentimes are asked to do presentations at our local schools about whatever topic of their choosing. We've done some mindfulness, some coping skills, suicide prevention training, warning signs, what to do if someone comes up to you indicating they're having suicidal thoughts. Since COVID, we've been asked to do more trainings on depression and anxiety because there's been a spike in those diagnoses with kids. So we go into the school and provide that training to their staff or their students, whichever they would like us to do. We also do observations at all of our local Head Start programs, identifying youth at risk or helping the Head Start providers deal with kids who have risky behaviors or high needs. Also do some parenting ed with the Head Start families. We do that also with the club, the Boys and Girls Club. We go in and train their staff on whatever topic they're asking, and then also do some parent training, parent interactive family fun nights is what they call them. So helping families interact with their kids and giving some parenting guidance. And then the last thing I have on my list is we also do, we participate in local law enforcement training, the mental health component for both adults and youth. So our staff go once a year and work with law enforcement and provide that mental health training for their law enforcement members.
So community mental health centers understand that they are part of the community, so they're not only providing the mental health services, but are also working to bring awareness to the community. And I know that we're running out of time here, so very briefly, Jason, when we prepared for this presentation and the four of us were talking, you had made the comment that relationships are the basis of change. So I'm wondering if you can maybe share just one or two very brief examples of how Three Rivers, how you and your staff are really a part of your community through some of the additional work that you do.
Yes, you know, relationships are the basis of change, and I believe a lot of that is building trust, respect, and empathy, you know, which is the opposite of trauma and exploitation. And one of the ways to build that trust is to be visible, to be there to help. I mean, we have lots of examples. We have staff that are involved in the schools, involved in the nursing homes, involved in community education, coaching, being involved in these events, both in our rural communities and with our tribal partners. You know, we also work with volunteer groups that we've brought in on suicide prevention, doing community education, you know, providing QPR training. So those are some of the ways that we do that, because to be visible is important in building that trust and building those relationships, because we can all think of individuals that have been impactful to us or been a mentor or a teacher. What are those qualities? It's usually somebody that you trust, somebody who shows some empathy, somebody that provides some direction, because we're about building therapeutic alliances, not just rapport. So I guess I'm going to just end with this quote by John Bowlby. I don't know if you've heard it, but it goes, what cannot be communicated to the mother cannot be communicated to the self. And basically what that means, or the way that I interpret it, is that unmet needs can be met through therapeutic alliances. So that's what I'm going to leave you with, and thank you.
Okay, thank you, Jason. And then just very briefly, Lindsay, if you could just kind of, I think you said this earlier, but if you could just share again how the services provided by a CMHC are different from some of the other services because of just that idea that they're community-based.
It really allows us to just meet the client where they're at. You know, Jason talked a lot about being solution focused and strength based, and that truly is where we're able to come from and meet them right where they're at by meeting with them in their home, in the community, whatever works best for them. And I think that really does make our services unique.
Thank you, Lindsay. And then Chris, finally, just to kind of close here, if you could talk just very briefly about the Prepare training that all of your youth and family services staff completed, and how this training is going to allow you to help your community and your schools in a time of crisis.
So last year, all of our youth and family staff completed a 2-day prepare training put on by Dr. Carrie Oyen and her team from the University of South Dakota. Prepare is an acronym. It's really long. I'm not going to go through what that means, but basically we were trained, and our local school district was trained on how to prepare for a traumatic event, how to respond to a traumatic event, whether that be man-made or human-made, and how to have a crisis protocol in place and ready to go. The Prepare model really talks about needing to have someone, the captain who's steering the ship, and then everybody kind of knowing what their role is within that crisis plan. The Prepare training helps you put a crisis protocol into place, because crises, as we all know, happen at any time of the day. And if you don't have a crisis protocol in place, it's very difficult to come up with one at the spur of the moment. So one of the big things out of the Prepare model is that there is a script that is put together when there is a tragedy. That script is put together by the team. That script goes out to all school staff, all counseling staff that may be coming in from a community mental health center, and that script is what is followed. You do not deviate from the script, because we have found if you deviate from the script, or there is no script, people start putting their own spin on things, rumors get started, and then things just get out of control. So the Prepare model also helps you triage your students, your staff. It uses a concentric circle model. You have those individuals that are close to the trauma, then you have those individuals further away from the trauma, and those on the outer circle of the trauma. But trauma impacts them all just the same, just on different levels, and they have different responses. It helps prepare how to respond to individuals if they are having a trauma response. And even if someone is not close to someone that may have died, based upon their own mental health issues, their own trauma, their own past, they may have a traumatic response, even though one wouldn't expect them to. So unfortunately, we have been called in to our local schools to handle crisis response. We have gone in for a natural disaster. We have gone in because there's been the unexpected death of a family, unexpected death of a student. What we do is school contacts us, asks us when to be there. We are there for as long and or as many hours or as many days as they need us there for support. We are just there to talk with anyone, be it students, be it staff, be it administration. We have found that sometimes the students are not comfortable talking to their teachers or their school counselor, but they are comfortable talking to someone that they don't know. So we're just an extra set of ears and support. And then at the end of the day, the prepare model asks that you do a wrap-up meeting. And at that meeting, the school decides who will attend it. And you sit down, you debrief, you talk about kids, students, staff at risk, talk about themes that you've heard throughout the day, process feelings, emotions, talk about what worked and what maybe you could do differently if unfortunately you have to use this model again down the road.
Thank you, Chris, and I want to thank all of my panelists for being here today. And I think that we're probably at, if not over our time. If anyone has questions, we can certainly take those. You can feel free to ask us right now. I don't know if we had any online questions.
We do.
Okay.
I'll borrow your mic for a second. Unfortunately, we don't have any more time because we have the next session, but feel free to put your questions in on the Whova app that we all have access to, and hopefully you'll be able to talk with our speakers on there. There's a question on that Whova app right now, but you answered it pretty well already. So thank you so much for your time.
Thank you.
We have a slight break, and in about 5 minutes, we're going to be all joining to listen to the 437 group talk on the main stage. Thank you.